So it is my great pleasure to introduce two people. First, to introduce Richard Asanoff, who runs a very powerful and important little, I don't know what you call it, an electronic magazine?
It's a digital newsletter.
A digital newsletter on healthcare called Convergence RI. And Richard knows more about healthcare and health policy, I think, in Rhode Island than I think anybody else. He's gotten interested in this process, wanted to watch what we're doing and how we do it together, and may have some questions for each of you as individuals, or for some of you as individuals on breaks and when we're done. Second, it is my great pleasure to introduce my colleague, Dr. Christine Pacheco, who is the Chief Medical Officer, that is the person who is to be respected at Blackstone. She's the big kahuna, and she is going to talk about dermatology. She's a family physician by training, trained like most of the family physicians in this community at Memorial, but she's way, way, way younger than I am. Dr. Pacheco.
Good morning. So this lecture will be as formal or informal as you want it to be. It will be as long or as short as you want it to be. It's going to require some audience participation, I'm afraid, so no sleeping. And so we're going to talk a little bit about dermatology and what we do in dermatology and primary care. I think if you're like me, there's a portion of your brain that's saying, what do I need to know about dermatology? Skin problems are not emergencies. Yeah? No?
Yep.
I think that's actually usually probably true. Let me see if I figure out how to do this. No, next one. There we go. So first I'm going to start talking about what do we do in primary care anyway. You probably have a sense going to your own doctor, going to your kids' doctors, your parents' doctors, what we do. We do a lot of well care, physicals, visits for well children. We do a lot of follow-ups for things like hypertension, diabetes, sort of chronic disease management. Both of those things are a little out of your wheelhouse, I think, if that's fair to say. And so, but the thing that we do is a lot of sort of urgent care sick visits. And like the emergency room, we see all comers. So you never know, as you probably know, you get a call and somebody's telling you this person has chest pain. You don't necessarily know until you get there, and maybe not even then, what kind of chest pain that is. Is that chest pain like I'm having a heart attack chest pain? Or is this chest pain like, I got kicked in the chest and now my chest hurts? Or is it really not chest pain? It's really kind of like over here. So triage is a problem. But we do see all comers, and I think that's pretty much it. Next slide. So one thing that you'll hear a lot of doctors talk about and other providers, common things are common. So the goal of this lecture isn't to get you to be able to diagnose things necessarily. Your goal, my goal for you, is for you to be able to distinguish between problems and not a problem. Needs to go to the ER, and I can take a big breath before I deal with this patient. I think this thing is clanging against, sorry. So we always say common things are common. So things like, what do we see in primary care? We see a lot of eczema, psoriasis, acne, contact dermatitis, scabies and lice, my personal favorite, and different kinds of infections, and of course moles and things like that. I've completely skipped over moles and pigmented lesions because I really don't think that's going to be something that you're going to see and have to deal with. Well, you'll see it, but you won't have to deal with it. So this is where you're going to have to start participating. So knowing that common things are common, and given the list of things that I just told you that we manage in primary care, I want you to take a look at this picture and see, throw a guess out there. What do you think this is? I've heard scabies, herpes, eczema. Any other guesses? What do you think that woman's doing with her neck? She's scratching it, right? So you guys are really good at using your context clues when you walk up to a situation and figure out. So we know this rash is itchy. This is actually, let's see if I can get it to float up like this is eczema. This is plain Jane eczema. I'm sure you've seen a ton of this. You may have this, your kids may have this, your grandma may have this. On the right is sort of the first stages of it, when it's itchy and a little red. Over here, this right here is a picture of eczema that's been scratched and scratched and scratched. You can see how they look pretty different, but they're still eczema. When it gets scratched and kind of thickened like this, we call this lichenification. That just means thickening. What about this? These are different things, actually. They're 3 different things, but they have a unifying force. Herpes is a great guess. So the one all the way to the right with the lips, herpes is a good guess. What about the one in the middle? It's like red and hot.
Spider. Cellulitis.
Good, all good guesses, great. And then this one all the way closest to me, ingrown hair with maybe some abscess underneath it, right? So all the way on the right, that's actually impetigo. Some people say impetigo. That is a bacterial infection, and it usually happens around the face. You can tell that it's that and not herpes because of its location. You're like, wait, but herpes is totally on your face. That's true. Herpes is usually on the lip line, on the lips themselves. This is a little off the lips, and you can see it has this sort of fun yellow crusting to it. We call that honey crusting. That is indicative of impetigo. In the middle is cellulitis. Cellulitis can be not a big deal or a really big deal. Cellulitis can come from bug bites, can come from spider bites. It can be at times very difficult or impossible to distinguish between a really inflamed bug bite that's been scratched and a cellulitis. They're both going to be warm, they're both going to be red, they're both going to be angry. You sort of draw the line with, is it painful versus is it itchy? Most bug bites are itchy, cellulitis is usually painful. They'll both blanch, which means when you touch it and let go, it'll turn white and then back to the reddish color. All right, so this is bacterial infections, it's sort of basic bacterial infections. Hold on, sorry. Okay, what about this? Psoriasis, that's right. How do you know it's psoriasis? How do we know anything in dermatology?
Because grandma has it.
Because your grandma has it. There you go. So when you're trying to decide what something is, and again, this isn't particularly what you're going to be doing, but when I'm trying to decide what something is, you have to remember real estate. Location, location, location. Are you going to get psoriasis on your lips? No. Are you going to get herpes on your elbows? No, generally not. So when you're seeing sort of thick, scaly stuff, what we call the extensor surfaces, do you guys use that word extensor? Okay, so extensor is like, so if I extend my arm that direction, all of that, that's my extensor surface. This is the extensor surface of my back, okay? If you see it on the extensor surface, you know that it's more likely to be psoriasis than anything else. And you can see that it's pretty mild on those legs, and you can see that it actually goes all the way up in the hair. And if you don't know what psoriasis is, and if you don't know that it can go in the scalp, this could really worry you, because this could look like a bad infection. If the person has a history of psoriasis, though, you know, okay, I can take a big breath. Oh. Okay, how about this fun one?
Poison ivy.
Poison ivy, how do you know?
Because I get it all the time.
Tell me about how it looks.
Disgusting.
Amen.
Bubbly.
Bubbly.
Blistery.
Perfect, yep. So the second sort of tenet of dermatology is, first is location, second is describe the spots. Okay, so let me see if I can go backwards. So we have these pink, we call them plaques because they're big, sort of all together one big spot. It's pink and it has some scale on it. So we would call that a pink plaque with scale. When you're looking at this, you're telling me you see bubbles. The fancy word we use is vesicles. So these are vesicles. How are vesicles different than pustules? There is
Clear liquid
versus pus. Yes, very good. So these are vesicles, and what kind of, here's the next step, ready? The distribution. So is it all one big plaque, or is it multiple little guys, and what kind of a distribution would you call that? How is that spaced? Yeah, it's a read my mind question. Linear, meaning these are all lined up over here on this picture on the left. No, it's your right. They're all in one line. Why does that happen? Because when you're walking and you walk up against poison ivy, the branch goes whoop across your arm, so you end up with a line. Now for poison ivy, what's the problem with poison ivy? What happens? How does that happen to you? Do we know?
oil.
It's the oil on the plant, right? And so if you, for instance, were digging out some poison ivy, and you got some poison ivy on the end of your shovel or your clippers, and then you put your clippers away, and then you come back next week and you take them out again and start using them, what's going to happen?
You get it.
You get it. Why? Because oil doesn't die. Oil doesn't freeze. It doesn't disappear. You have to really clean it, and you have to dilute it. So you'll hear people talk all the time about poison ivy and how they're like, well, but I keep getting it. It finds new places. It keeps coming in different places. If you pop the blister, then it spreads. It doesn't spread based upon the blister. It spreads based upon the oil. So the clothes you were wearing, the gloves you might have been wearing, whatever tools you were using, you touched them again, something touched you again with the oil, and that's how you ended up with the poison ivy. Poison oak looks a lot like this. Other contact dermatitis, we call it contact because you're making contact, and dermatitis is inflammation of the skin. This can happen with lots of things, by the way. So I don't know if you've ever seen this. You probably have on patients where you lift up their shirt and you're looking at their belly and they have a spot that looks a little like this on their belly button. Anybody seen that? Usually comes from your pants, especially jeans. The buckle of your pants has nickel on the back of it and can cause a little red spot. You haven't seen it yet. You will see it next time you do it. You'll see it and you'll be like, oh, nickel allergy. How about this? Shingles, how do you know?
Have patience with it.
You've had patients with it. What does it look like to you?
Like that.
It looks like the poison ivy.
It looks a lot like poison ivy because it's also vesicles. What about the distribution? So this one, it is painful. This one's linear on the right, and actually you can see lines on that other one, right? You can see that it was a line. You can imagine a branch doing that to you. What about this one? Is that linear?
I think I get picture traumas.
You are?
Inside joke.
You're getting picture trauma?
No, they're saying because he's got a big nose, I got a big nose.
Oh, that's a sad story. It is what it is. I have to tell you, dermatology was my least favorite thing in medical school because the pictures were the most disgusting. I hated it. I hated it. I hated it.
She's saying your nose is disgusting.
But I kind of love it. Your nose is beautiful.
They'll feed into this.
All right, I'm not going to say another word. All right, so we've got blotches. Blotches. Another way to say blotches is clusters. So they're clusters of bubbles or vesicles. And what about the distribution, like where on the body? Location, location, location. It's kind of a side, right? It goes like this. So if I hit this button, this is something called dermatomal. Have you guys ever heard of dermatomal? Probably not, right? So your body's nerves that live in your spinal cord, which you've probably learned about, go out and provide sensation in these sort of, in this map, okay? And so if you're, shingles is an infection of what part of your body? It's your what? Nerve endings, right? And your immune system is playing a role here. It's not doing a great job keeping it at bay. Because once you got chicken pox, which we probably all have, maybe not because some of you are very young, that virus is going to stay in your nerve endings for the rest of your life. Shingles is that thing coming back again. Same thing with herpes, with oral herpes and genital herpes. So anyway, you can kind of see, if you look at this dermatomal map, that this here is the dermatome here. It's like the T3, T4 dermatome. You don't need to know what dermatome, but if you have this picture, the zebra stripe picture in your mind, and you see a rash that's taking up a couple of dermatomes in the pattern of a dermatome, you might say to yourself, okay, that's shingles. What about this poor guy with the nose? What's the scoop with him? Yeah. I mean, the problem with shingles is, again, it likes nerve endings, right? And so you've got nerve endings on your face, and what you can't see in this picture is that the dermatomes for your face go like this. They continue like zebra stripes. They go like this, okay? And so what he has is an infection of this dermatome. What do you notice? Actually, it's hard to see in this picture, but what do you notice especially about the man with the nose?
It's miserable.
He looks miserable. He's definitely swollen. There's a part of his body nearby that looks like it could get affected. It's a very important part of your body. You have two of them. Eyes, right. Can you get shingles in your eyes? Yes. Is that a disaster? It can be. It totally can be. So whenever we see shingles on the face, we worry about the eyes and we send them to the optometrist or ophthalmologist to take a look in there and see if they see anything. And if they do, get them early treatment, because we don't want problems with the eyes, right? We only have two.
And we're lucky at Blackstone because
We have an optometrist.
who everybody just met.
Oh, good. Excellent. The other thing I want to point out, and this is a read my mind kind of question, it won't cross the midline. It's only his right. It's not his left. It's only this lady's left. It's not her right. If you have something that crosses across the midline, it's probably not shingles. It's probably either herpes, like genital herpes or HSV1, or some other bubble-forming disease.
Would it only
Is that
affect
contagious
one
from
side?
touching?
So, unlike poison ivy, the answer to that is yes. Any spots that are open can spread the virus. Now, if you haven't had chickenpox here, you've probably been vaccinated against it to be able to do your job. But if you have a baby under the age of 1, because 1 is the age at which we vaccinate babies for chickenpox, if you have a baby under the age of 1, you would want to keep that baby away from this gentleman because he can't cover it. If this lady over here can cover her skin, it's fine. She can go to the supermarket, not a problem. It's contact with the open spots, okay? But again, most of us have probably been vaccinated in order to work here, so it's probably not an issue for you. It's an issue for either the pregnant lady who hasn't been vaccinated or had it, of which there are very few these days, or the baby under the age of a year or an unvaccinated child. Okay, so shingles or zoster. I'm sorry that didn't come out very good, did it? And then, what's going on? Oh, there it is, dermatome map, okay. Maybe I'm not pointing it in the right direction. There we go. Okay, what are we looking at here? Guess. It's okay to guess. No points off.
Ringworm.
Good. What else? What? Athlete's foot. What is the common denominator between ringworm and athlete's foot? Fungus. So these are fungal infections. So on the top left, you have, actually it's hard to see what body part that is, but I think it's fair to say that it's a fungus. On the right is athlete's foot caused by tinea pedis. On the bottom is something called tinea versicolor. I would be willing to bet you've seen this rash before and not known what it was and not even paid any attention to it. It's just a different kind of fungus. Is it dangerous? No. Is athlete's foot dangerous? No. It's not something you particularly have to worry about. I guess that there's a large chunk of the patients that you pick up that have one of these tinea infections. Oh, goodness. I guess that the size might be different than it was on my computer because it looks like that. Okay, what's this? I'll give you a hint. I said it was my favorite, which is a lie. That's right, scabies and lice. Okay, on the left, or on your left, the top left right there, that's scabies. How do you know it's scabies?
You said so.
How do I know it's scabies? Because I'm a doctor.
We can do this all
Super
day.
fun.
I promise.
Because I'm wicked smart. Okay, on the top left, this is a hand. I think you can imagine that there's like a thumb here. Scabies like certain parts of the body, and I think this is something you probably maybe worry about a lot. You probably pick up people with scabies all the time, and you're like, oh God, I hope I don't get scabies. Is that fair to say, or not really? You guys don't care. You're like, whatevs. I'm fine.
I think you see more bed bugs.
Okay, well, this one down here is bed
When's
bugs.
the last time I saw
Scabies on the top left, lice on the top right. Are lice dangerous?
Disgusting.
No, they're not dangerous, but they are gross. Scabies, generally not dangerous either, but causes a lot of suffering. Very, very itchy, very unpleasant. Does it, and you can only spread it, generally speaking, sharing bedclothes, beds, towels, really close contact, not picking up somebody and moving them, but really like spending some time with them. Same with bed bugs. Do you notice something about the scabies versus the bed bugs? Do you see anything visually that's different?
Yeah, the scabies is bright red.
Mm-hmm.
And clustered.
And a little more clustered, yep, and it's on the hand as opposed to the leg. My point really is, though, it's really hard to tell. Patients come to me with all kinds of bites, and they're like, what's biting me? And I don't generally know very well. I can use location, so that center thing there shows you where scabies like to bite. It's basically the groin, the hands, and a little bit of torso. If you're seeing stuff on the calves and the thighs, you're probably thinking more bed bugs. Sometimes you treat someone for both because you're not really sure which one it is. But in any case, none of these things should be too worrisome to you. You're not going to pick up bed bugs by picking up someone who has bed bugs and driving them to the emergency room. So if I just got through telling you that, you know, common things are common and that most dermatologic things aren't a big deal, like you don't have to worry too much about them. So when do you need to worry? So the lesson I want you to take home, and this will come back as a question for you later. When do you need to worry? Well, you're going to use the skills you already have. You do vital signs, right? And you have an assessment, and some of it's sort of a gut assessment. This person is sick or they're not sick. I'm worried or I'm not worried. So you're going to use, that's the most important thing, because almost any rash with normal vital signs is okay. But if you have abnormal vital signs in a rash, the rash might be fine, but the person isn't. So you want to make sure you're focused on those pieces, okay? What kinds of things do you guys use to decide if someone's sick or not sick? I mean, I know what I use, but I don't know what you use. How do you decide this person looks sick or not really? Temperature?
See if they're septic?
What?
You asking like to see if they're septic?
No, I mean when you go to see someone and they're like,
General impression.
Oh, like general impression.
your general impression, exactly. It's really hard to put your finger on exactly what you do. They're not talking right, they're drooling, they're not paying attention, and you don't always know whether that's an acute problem or something they've had a long time and they're actually calling you about something else. But that general impression, that gut feeling you have from having done this job is what I want you to go with. Red flags, you're looking for altered vital signs, specifically increased respiratory rate. Do you guys do a respiratory rate? Is that something you do?
Yes.
Yeah. So you have a sense of what's a normal respiratory rate for a 2-year-old versus an adult?
Yes.
Right, so everybody's respiratory rate's probably a little high by the time they see you. But you have a sense of like how high is too high. Also decreased blood pressure. Sometimes everyone comes and they're bragging about how low their blood pressure is, but when you see them and their blood pressure's low, you probably start to sweat a little bit, huh? Fever. Here's another thing. Mucous membrane involvement. What's a mucous membrane?
Mouth, nose,
Right, eyes.
eyes,
So if you see a rash that extends into the mucous membranes, that's a rash I want you to think hard about and think something's up. This could potentially be pretty dangerous, especially if you see the mucous membrane involvement with altered vital signs. That's when you want to be really thinking about this person's got to get to the hospital sooner rather than later. Is this kid sick or not sick? How do you know? It doesn't look good. All right, so this is a kid with meningococcemia. What the hell does that mean? That is meningitis, but the meningitis bacteria has gone throughout his whole body. And you can tell because you have all of these non-blanching. What does blanching mean? When you push on them, they go white and then they come back. These don't blanch. This is bleeding essentially into the skin. This is a kid who's in deep doo-doo. Sick or not sick?
Yeah.
I told you, I warned you. Sick or not sick?
very sick.
Very sick. On the left, what you're seeing is sloughing of skin. Do you see how like there's hardly any skin left? You're just looking at dermis now, which is the deepest part of the skin before you get to the fat and the muscle on the left-hand side. If you see somebody who looks like this, they've either been burned or they have an illness that's causing their skin to behave like they're burned, in which case they're in deep doo-doo. This person in the middle, what do they have that makes you worry that I warned you about?
Mucous membrane.
Mucous membrane involvement. That doesn't look very good. What about the person on the right? Mucous membrane involvement again, right? So this is not great. Now, this is TEN, or toxic epidermal necrolysis. This is a pretty dangerous situation. This person may not live another 12 hours by the time you see them looking like this. Sick or not sick?
Not sick.
It feels that way, doesn't it? This is actually toxic shock syndrome. Oh, it didn't, okay. Sorry, it's toxic shock syndrome, or TSS. Has anyone ever heard of toxic shock? I'm guessing part of this is because you're all men in here. And one thing you learn early as a young girl is that tampons are associated with toxic shock syndrome. We all know what a tampon is?
Yep.
No? You got it? Okay, it's something for menstruation, right? So if you leave that tampon in for too long, you can get something called toxic shock syndrome. Does that happen a lot with tampons? No, it doesn't. But do you get the bejesus scared out of you as a young girl? Yes, you do. Toxic shock syndrome is actually pretty dangerous. It looks a lot like this one at later stages. This is an early stage. But you can see that there's some skin sloughing happening here too. Whenever you see like layers and chunks of skin coming off, you should be worried. That's not normal. Can you get toxic shock from things other than tampons though?
I hope not.
The answer is yes, you totally can. It's basically any kind of bacterial infection can do this to you. Sick or not sick? Yeah, we're bordering on anaphylaxis. This is sick. This is something called angioedema. It's an allergic reaction that affects the mucous membranes, right? And so You know what's kind of interesting now that I look at it is it's only one eye on her part, which might make you think is there shingles under there, but no. It's her eye on both sides of her lips. This can happen from ACE inhibitors like lisinopril or enalapril. It can happen to bee stings. It can happen to anything really, foods, anything you can be allergic to, which is anything, can cause angioedema. If you're seeing this, you're thinking about hospital. And while you're in the field, you're thinking about, I need to make sure I secure the airway. That's right. Sick or not sick? Sick. How do you know?
That looks bad.
It looks bad. We have things that are not blanching. You can see there's bleeding into the skin, and you can see sloughing of the skin. What do I mean when I say sloughing? Like just chunks are coming off. It's like falling off, right? Okay, so this is something called necrotizing fasciitis. This is also called flesh eating. Like the sort of lay term is flesh eating skin infection. So this is also pretty dangerous. This is limb threatening, if not life threatening.
If that looked like that, they're already septic, right?
Not necessarily, but they're probably getting there. So you're going to move faster rather than, not that you take your time, but you know what I'm saying. Here's case number 1. This is a 20-month-old male. Mom is complaining of 2 days of fever, temperatures to 101, and some fussiness. She's called the ambulance. So here you are. You do some vital signs. His temperature is 101.1. His respiratory rate is 60, remembering he's 20 months old. His pulse is 170. His blood pressure is 88/42. He's fussy and irritable. Is this kid sick or not sick? How do you know? His vital signs look kind of like garbage, right? He's still making you sweat. What about the rash? Does the rash worry you?
It does with the fever.
Yep. Part 2. Okay, same kid, same rash. Not the same kid, maybe brother. Same rash. 20-month-old male. Mom complains of 2 days of fever and fussiness. Temperature of 101, respiratory rate of 24, pulse of 110, blood pressure 88/42. Kid is fussy but consolable. Sick or not sick? Not really. Yeah, this is a kid I would see all the time. Why? Vital signs. All those vital signs are okay except for the fever. How many of us have had a fever, a kid with a fever of 101 at home? Not a lot of parents here. If your kid has 101 fever at home, do you call an ambulance? No. Do you take him to the hospital? Do you take him to the doctor? Maybe. Maybe. This is a viral exanthem. These can be fine or not fine. Use your vital signs. Okay, that's what's going to guide you. Case 2, it's a Thursday about 4 in the afternoon. You get called to a college campus. I don't know what we want to call it. Let's say PC. To evaluate a 20-year-old college student. He's been acting crazy. He's disoriented and at times aggressive. You are like walking by all the bars as people are starting to walk in. What are you thinking?
Meningitis.
I love that you're thinking meningitis, but if you didn't see the bottom part, he's acting crazy. He's 20. It's 4 o'clock on a Thursday.
Drunk.
You're thinking he's drunk, right?
Yeah.
That's what I would be thinking. You reach out to touch him and he is hot, and then you see his hands. You're right, meningitis. This should make you sweat. This is somebody you want to get to the hospital now. So I'm actually already almost done in half the time, so I'm sorry / thank you. / you're welcome. To say the vast majority of skin problems are not an emergency, but when they are, you will know using the skills you already have. You have that gut intuition, that experience, that look test. The kid passes the look test or they don't, and you're going to use the vital signs. Questions? Yes, sir.
So something I think maybe we all see a little more common, bad circulation, and, the individuals who maybe don't take care of themselves so much, and they have the swelling, lower extremities, cellulitis, open wounds that are leaking, yellow.
Stuff.
Yeah. What about that? Is that something?
So I would again, so the problem is how quickly did it develop, right? So this is the doctor in me, but this isn't really going to help you. For you, I would use my vital signs. If the person has hypotension, tachycardia, I'd be starting to worry about sepsis. This person needs to go to the hospital yesterday. If these are things that have been sitting there for 3 or 4 days, they've got to, what?
Well, before you get to where I think you're going,
Okay.
The thing I would counsel is look at your inclusion criteria.
Oh, certainly, sorry.
we're trying to stay strictly to the inclusion criteria we all developed together, so cellulitis and edema are not part of the inclusion criteria. So at least for the moment, till we get good
Send
at
them.
this, get used to working together, they go to the hospital, that may change over time, but I think, for the first couple of months, if it's not the inclusion criteria, it's at the hospital.
Okay, so what we're saying is that if what you're seeing doesn't fall into your inclusion criteria, you're transporting to the hospital.
But conversely, rash is an inclusion criteria. So I think what you're hearing is, and I'm looking at tinkering with the exclusion criteria a little bit, but what you're hearing is rash with the exception of mucous membrane involvement, skin sloughing, or massively altered vital signs. They are part of what will come to express care and deserve a phone call.
Is your question, what would I do with that, or is your question, where should you transport it?
Yeah, I guess a little bit of both,
So to answer the first part of the question, which I think I'm much better qualified to answer, again, it has to do with the vital signs and how long it's taken to develop. If this is spewing stuff and it started 2 or 3 days ago and the vital signs look like garbage, they're going to the hospital. Even if they come to my office first, I'm calling you to come back and get them and take them to the hospital. If it's a cellulitis that's developed in an otherwise healthy person over the course of 3 or 4 days and maybe they had a bug bite or they're not sure, I'll treat those outpatient.
Why does it happen? Why do we see people living with their legs like this for months on end sometimes?
So cellulitis, wounds, abscesses all have to do with the basic function of skin. The basic function of skin is, what do you think? Sure, it's a barrier and it helps keep your heat in / cool you off with sweat, but also keep the bacteria and germs on the outside and your guts on the inside, right? And you're trying to create separation because inside we're sterile, except for our gut and our skin. And so it's a barrier, that's what it does. And so when you get a cellulitis, when you get an abscess, when you get a wound, all of that has to do with a breakdown of the barrier. And so that can happen with a bug bite for a young kid or, who wiped out or, scraped their knee. It can happen after an MVA when you break the skin. But for especially older folks who are what we might call vasculopaths, so they're people who either because of diabetes, bad coronary artery disease, peripheral vascular disease, smoking, their blood vessels don't behave like a normal person's blood vessels, and so the immune system can't get there. And so how many of us have wiped out and skinned our knee and not gotten an infection from that? Right? Why do you not get an infection from that? Is it because there's no bacteria on the ground or on your leg? No, it's because your body, your immune system, fixes it. It gets rid of it. It flushes it with some goo and some bleeding, and then it sends the immune system there to kill any germs that are still lingering, and then it starts to close itself up in a reasonable amount of time, right? It might take 2 to 3 days to a week to close up a skinned knee in a healthy kid / one of us. If you're a vasculopath, what that means is that the blood flow is poor because your arteries are hardened and the blood isn't flowing very well. When that happens, small things will cause big infections because the immune system can't get there to fight off germs, and also because the blood flow can't get there to start closing up the skin in a normal way. Does that make sense? So it's sort of at least 2 pieces. I don't know if you think I'm missing anything about that.
No, I think that's actually perfect. One of the things that we've emphasized is that the EMT in the field is the person who makes the decision.
Mm-hmm.
And the EMT in the field has total control over whether to call or not to call to bring somebody to express. That if it's their instinct that this is worse, they just can skip the express process and go right to the hospital. And that's where the assessment of things like, does somebody look really sick?
Mm-hmm.
Or, is this somebody who's, got so much complex disease, like somebody with bad diabetes who's a smoker, who's got an amputation already and has a bad cellulitis. That's the kind of person that, you don't pass go, you don't collect $200. You can just go to the ED because that person's going to need to get admitted for IV antibiotics most likely. But the thing I want to emphasize is it's the EMT in the field who makes the call. You know, these are guidelines, but we're here to support what you do, because you're there, you're at the bedside, you're with the patient.
Other questions? Did I answer your question sufficiently?
Yes. Yes. Thank you.
Nothing else? I don't know if you want to pull up your, that's the end for me.
Well, a round of applause.
Oh.